Hello, I'm Dr. Jonathan Silverberg. I'm an associate professor in the Department of Dermatology at the George Washington University School of Medicine and Health Sciences in Washington, D.C. Welcome to the second episode of the Innovations in Dermatology podcast titled The Adult Atopic Dermatitis Challenge. Joining me today is Professor Emma Gutman-Yaski, who is the Waldman Professor and System Chair at the Icahn School of Medicine at Mount Sinai in New York. Welcome.
Hi.
We're facing many new treatment options coming to atopic dermatitis. We have one systemic or biologic treatment currently approved and may have many more by the end of the year. With new systemic treatment options available, it's going to be increasingly important to understand where they fit in the treatment paradigm. Today, we're going to talk about a couple of challenging cases and discuss our treatment strategies. So I'll start with the first case. This is a patient who is a young adult female who presents to the office for evaluation for atopic dermatitis. And the patient comes in with literally a rollaway suitcase of topical prescription therapy. And I think we've all had those patients. And this is somebody who has experienced 6 flares of atopic dermatitis in the past year. She endorses that she's always using topicals, which initially she'll tell you that, the topicals, they don't work. They failed. They didn't do anything for my atopic dermatitis. But then when I asked her, in particular, wait, did it not work at all? Or did it work for a few weeks and you stopped using it and then it came back again? And almost invariably, when you ask that probing question, the answer is the latter. It did work for the first couple of weeks, but I stopped it because that's what my previous dermatologist told me to do. And things never really got better, or they came right back again. And this is someone who's got a body surface area of 35%, but you certainly encounter patients with even more than that, who endorses sleep disturbances for at least a couple of nights a week, sometimes even more than that. And on average, a 7 out of 10 itch. And, so this is a patient that unfortunately is all too common. Certainly the chronicity of disease is there. Patient has extensive disease. Body surface area is obviously very important from a severity standpoint, has impacts in terms of sleep disturbance, severe itch. And then the big question is, so now what do we do with a patient like this? And it's not easy. For me, this was one of those types of cases where, yes, there may be opportunities to optimize topical therapy, and I certainly like to have that conversation where before definitively stepping up, I will try to at least discuss opportunities for optimizing topical therapy. But when they walk in with that suitcase of topicals, I kind of know at that point, there's only so much benefit I'm going to get out of those topicals. And I almost immediately will engage in that conversation, that shared decision-making conversation about systemics and biologics and phototherapy and stepping up therapy. I'm curious your thoughts, Emma. How do you sort of approach this? When do you, make that decision of when is a systemic treatment warranted versus, when should you give it one more try on topical therapy?
Yeah, so, I think you pointed exactly to the things that I'm considering as well. It's very important to know the patient and what they want to do. And I think the shared decision-making is so important because there are patients that I'm on the fence on giving them a systemic, but they are very interested in the systemic because they feel that the disease affects all the aspects of their lives, takes over their life, and even with more minimal disease, but in let's say sensitive areas such as the face, hands, and feet. So they tried everything, and we know that particularly in these areas, the disease comes back after a while. So one is the patient's request. When you, of course, think it's the systemic is warranted. The second scenario is there are many cases that I think they really deserve it. Let's say patient body surface area 30% and even higher. But then the patient is a little bit hesitant to get a systemic. So I think you need to spend the time, explain to the patient that, listen, you had the disease already 30 years, you exhausted all the topicals. My options are very limited now because they come to you, oh, doctor, can you find something else? And when you run out of options, topical options, I think you need to address the idea that right now we don't have other options. And when you have that much of body surface area involved, likely it's in your blood. So you have systemic immune abnormalities, and just topical treatment will not help you enough. And we need to step up and go to a systemic. But it's certainly a discussion. And I think it's hard sometimes for patients to accept the idea that they need a systemic, because I think it emphasizes for them that the disease is chronic. And I think it's an important discussion with the patient.
Absolutely. And, I think you touched upon a point that really resonates with me in particular, which is, this idea of a quick fix is not enough. And so, the topical therapies for many patients who have 365 days a year of disease, or even just 200 days a year of disease, there's only so much they can use the topical therapies in the same areas over and over again. So even when they get a short-term response, but that doesn't fix anything in the long term. And so for me, part of the decision of stepping up therapy, it's not just did they fail topical therapy in the first 2 to 3 weeks. That rarely happens. It's more about the fact that they may even get better with topical therapy, but they eventually have to stop. And when they do, they flare. And now what do I do as a steroid-sparing option? And so I think it's such an important point that we really need to be crafting long-term treatment approaches, whether topical or systemic for that matter. So Emma, maybe you can take us through your case as well, which I think is also very much along these lines, a very important scenario.
Yeah, no, absolutely. And I couldn't agree more, Jonathan, with everything said. So case number 2 is a patient that has been treated with short courses of oral prednisone. And the patient experiences an exacerbation in itch after the end of each course. The patient has 10% body surface area initially, but that 10% increased now to 20 to 30% body surface area. And I must say that in my own clinic, I never give courses of oral prednisone. And I'm a strong advocate against oral prednisone, because what happens is you basically condemn the patient to a life of misery, because the moment they stop it, not only they get all the disease back, but they also get more. So you start a cycle that afterwards it's very hard to break. And I never go on this path. I know that some patients are like, oh, doctor, I have a wedding to attend. I have something. Can you give it to me? I say no, because at the end, I'm not doing you a service. And I think it's very important for us as treating physicians not to go down that path. We have good treatments now that we can give the patients. Maybe they will not work immediately like steroids, but they are much, much better for long-term disease control. And I think Jonathan touched upon the idea that we need to think long-term. We cannot think just short-term. So some key questions that we need to address: what to do in these cases? When should a patient be referred to specialty care? When is systemic treatment warranted? And what considerations to take into account when weighing the risks and benefits of systemic therapy? So I think the most important thing that we need to do when we think about treating a patient is not to think only about next week. You have to think long term. And you need to position the patient as somebody that had the disease quite some time, right? It's not poison ivy. It's not that this just happened yesterday and you just want a quick fix and everything will be great. The patient has it likely many years, and giving again oral prednisone will just make it worse long term. So this is not addressing the source of the problem, that is that type 2 inflammation. And now we have very good treatments for that type 2 inflammation. So we do not need to go to non-specific treatments that will cause long-term exacerbations.
I think these are all outstanding points. I share your dislike for oral steroids, and unless I have, the insurance just won't cover anything else in some rare situation, I almost never use them. I do feel like there probably is some subset out there where oral steroids might be enough, but that's the patient who maybe has like one flare a year in the winter time that lasts 2 to 3 weeks, and maybe a quick fix might be enough. But that's not a patient who's ending up in dermatology, right? That's someone maybe who's getting managed predominantly in the primary care setting. And I agree with you. Patients will say that using oral steroids is like using crack cocaine, because they feel so good when they're on it, but then instantly, not even like a week later, instantly when they stop it, they start feeling sick again. And it's just, then that's where they get hooked. And we've had patients who, someone started them on a short course of prednisone 10 years earlier, and they could never wean off. They never thought of giving them a long-term treatment option. And then these patients end up being on some dose of steroids for a decade. And then all they get, they have all the comorbidities and adrenal insufficiency and all the problems because of it. So I completely agree. I think that, now there's a lot for us to consider with the new treatment options, right? Because currently our only approved option is dupilumab. And in general, when we think about biologics, we're not going to use biologics intermittently in a general sense, because we'd be worried about immunogenicity concerns. But now we have, the oral JAK inhibitors in development, and we look forward to having them approved soon. And, they're very rapid and very robust efficacy for those drugs. But I think even when we're using them, we have to be very cognizant of the needs for long-term control, and not just trying to use them only as this like 2-week course and a quick fix. So I think we're going to have a lot more to discuss, and a lot more to add to those therapy, shared decision-making conversations with patients. But it's really nice to have new options and to really figure out how to use them to tailor to individual patient needs.
Yeah, no, I couldn't put it better. I think we have the option to really change the paradigm of treatment of patients with atopic dermatitis. And we also need to consider we'll have many options. Some are treating also comorbidities of atopic dermatitis. And when we think about what treatment for what patient, we need to understand what comorbidity the patient has, the wishes of the patient, whether the patient also wants to treat that comorbidity, and sometimes talk to the treating physician that treats the asthma or the food allergies or eosinophilic esophagitis, and then take a shared decision making with all this in mind to best benefit the patient and address everything. And when I'm talking about these comorbidities, they are all systemic comorbidities. So it's very clear that we'll not be able to solve it just with a topical.
Absolutely agree. And then I think finally, and this will be specific to any drug you're thinking about. Of course, you always want to take into account safety, risk-benefit ratio. And I think we don't have enough time to cover that in today's conversation, because it really will depend on each individual drug. But now, with a new toolbox, I encourage everyone to really stay as up to date as possible on all the new data, because there's just so much new information on both safety and efficacy of these therapeutics. So, Emma, thank you so much for this outstanding conversation. And thank you to the audience for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.